Hello and welcome. Today my guest is Dr. Nathan Riley. He's an incredible person, but he also happens to be an OBGYN and a palliative and hospice care doctor. He has some really interesting things to share, and I think you're really going to enjoy the interview. If you're new to my channel, go ahead and subscribe below because every subscription helps get the information out. You can also like this video and comment below. That helps get this information out to those who need it because of YouTube's algorithms. So welcome. Thanks so much for joining me, and enjoy the interview.
Well, hi, friend.
Hi.
Now that you're set up, it's good to see your face. Yeah. You too. And congratulations on the baby, and also a massive shift in your life, because I love that. Was that like a plug for the OBGYN? Like, let's just slow that down for a second. Just to introduce you, here we go. The OBGYN is on with us. Hi. What wine are you drinking tonight?
You know what? I have to go and check it, but it's always a Chardonnay. If it's a white wine, it's only Chardonnay. It's the only thing that works in our household. So we try something new every time. We have a formula. When we go to the store, you go and find a bottle. This is something anybody out there can do.
Okay.
You find a bottle that's priced. Generally, the MSRP, the retail price, is generally $15 to $20, and you buy it on sale. And if you can get it like $9 to $11, and then get that like buy 6, get the 20% off thing, that's the way to buy wine. You get good wine, and you don't like waste your money on the $30 bottles. None of that business. No $2 Chuck here.
Yeah, none of that. Well, I'm so happy to have you on our call today. And, you know, so much has happened in the world. So much has happened in your life. I really wanted to talk to you to get your clinical perspective, and then professional / personal opinion out there, if you're willing. There are so many pregnant people right now who are really overwhelmed by the recommendations that are coming down through mainstream, and there are so many folks who are considering making alternative choices. And I thought that having a real live OBGYN's opinions and experiences would be really helpful. So that's why I was hoping we could have this chat today. And then, of course, it's just good to see you and catch up.
Absolutely. Yeah. I have a lot to say about this topic, as you and I
thought you might.
Discussed. Yeah. So where to start? I think one of the things that I think was most important to me when you brought the topic up was, we'll get into like the home birth conversation, but what are we doing clinically now in the hospitalized system of taking care of women through pregnancy? What have we gotten so accustomed to that now in the age of COVID, we can't have anymore? And is it really changing the outcomes? And what I mean by that is, the general system by which the sort of hospital-based approach, because I don't really have another way of saying it, but you know what I mean by that. Not the community-based midwife, not the, hey, let's get together and let's have an hour-long conversation about what pregnancy means to you. I mean the, hey, you check in at the desk at the clinic, you're in a room filled with 20 other women at various stages of their pregnancy, or just GYN patients in general. They sign you in, they go and collect your vital signs, they collect a urine sample, you sit on a scratchy piece of paper, they maybe talk to you about like getting the Tdap vaccine or whatever the hell it is that they're promoting at this visit. And then they maybe do an ultrasound, they maybe do a Doppler, get some Dop tones, right? And then they check your ankles and they smile and they pat you on the head and you leave. That's the general sort of format for outpatient prenatal care. Well, what we're seeing now with COVID is that most of those visits are being canceled. And that's not to say that all of the visits are being canceled, or if that you're a super high risk patient that you're not going to have your support, in your diabetes management. But for the vast majority of women who are getting pregnant, you are low risk. And what we're seeing is they're getting phone calls to cancel all those appointments. So it makes me wonder, how important were those appointments, to begin with? And especially for the low risk women who would otherwise consider seeking, out of hospital prenatal care, whether it be a physician, a midwife, or fully going free birth, right? I mean, going completely in the other direction. What does that really mean? And are we seeing that outcomes are worse now, that we're not able to check on your baby's fluid every single time you come into the clinic? And the answer is no. So in the age of COVID, we're now having to pull this veil down that we've all been using to deceive ourselves from the very beginning of your residency training as an OBGYN, where this veil is now falling, and we're having to sort of reconcile the reality that, most of these visits, most of the things that we're doing in the name of safety for women throughout their prenatal care are actually just making us feel better. Maybe they're making us feel better. And more importantly, they're helping us bill for more money from insurance companies, which is important, but it's not the whole thing,
Well,
So
billing for more money is not important.
Right,
Billing for some money is important.
Right. We need to make some money. Yes, that is definitely true. But, do we need to do that ultrasound and bill for that ultrasound and all these other things? And probably not. We're probably doing more than we have to, and now we're all being forced to sort of admit that. And I don't have a clinical practice right now, but I can tell you all of my friends that have clinical practice have said, well, I don't have as many OB patients now, and it's only the high risk patients that are coming in. And it's sort of like, tell me more.
That might be the balance we've been suggesting for a long time. That's
Maybe every 2 weeks or every 4 weeks is really unnecessary for, like my wife. We just had this baby, and she's 6,
congratulations.
7 weeks old, and thank you.
Yeah.
And throughout her care, Stephanie had to remind me to not have a look on my face that would have probably conveyed, like, do we really have to do that? And she's like, you know what? I get it. You know a lot. You're the smartest man alive. Whatever. She's doing all those things. I've been my wife now for some time, and so she also gets me. Like, she can read my face without even knowing what's on my mind, and
of course.
knowing how I'm. She knows exactly how I'm feeling without really even hearing or whatever.
Fantastic.
But one example is when she went into the clinic at, I think she was 37 weeks pregnant. She had said a couple of days before that, she had said, it's funny to sit down now. And I was like, well, tell me more about that. She said, it kind of feels like there's something there, like a ball there. She's like, I don't feel like I'm giving birth. She said, it just feels different, because as we all know, the pelvis starts to relax, the baby starts to engage, and maybe even start a little bit of descent there. And and her body's preparing for this natural physiologic process. Well, when she went into the clinic, suddenly her fundal height 1 week ago was normal, and now it's suddenly 3 centimeters behind or whatever. And gosh, did the baby shrink? What the hell happened here? So they took her for an ultrasound, and she said, hey, they're going to get an ultrasound. I wasn't there because I was at work at the time. And I said, okay, all right. Like, I don't want to be the doctor. I want to be the partner. And I said, that's fine. I'm sure everything's fine. And of course, they were looking to measure the baby's growth, but when they do the ultrasound, they also look at the fluid, and they measure all these pockets of fluid. And if the fluid is borderline low or whatever else, then they might even say, hey, you know what, actually, 39 weeks. Unfortunately, they didn't recommend, they didn't find a reason to recommend induction of labor and all that stuff, because that would have set us on a very different path. And, I just think, man, did we even need to go in at 39 weeks? Probably not. But now in the age of COVID, that visit probably wouldn't have happened. For all I know. Right. And it wouldn't have changed any of the outcomes.
It's a very interesting sort of experiment that many industries are going through, but obstetrics specifically. And I love you highlighting that idea that a whole bunch of previously emergency and necessary tactics and techniques and interventions are now completely off the table, and ta-da, people look to be doing just fine.
We're doing great. Yeah.
So interesting. Well, we've heard reports. I know that that I've been talking to lots of midwives around the country and other experts, and we've heard reports of practicing OBGYNs who in many parts of the country have been the worst critics of midwives, who in the span of a very short amount of weeks switch their tune to saying, you need to find a midwife or a birth center. Don't come back to me. It's too dangerous for you to be here, to their client.
Right.
What is I mean, like, from an inside perspective, what is happening there? Because there are a lot of midwives whose mouths are actually hanging open. Like, Doctor Who said what? Because he used to hate me, What is that about?
So a couple of things have happened, and I don't think that I didn't anticipate that home birth was going to become a popular right away, but it is certainly becoming an option for people who would have otherwise thought maybe that isn't the right thing for me,
Right.
And I think that the medical system is now supporting that. And I think part of it is sort of like what we said, there's not really a way to support women in the outpatient, through the hospital track. There's not really a way to support them in the outpatient setting. And so they know that if, hey, at least you're linked in with a midwife, you're going to be getting prenatal care, because we have we've really been trained with this idea that this is a pathology. And if we're not looking for something bad, then if we miss something that we weren't looking for, that somehow it's going to send our patient down the tracks to a really bad outcome, right? So they want to know that they're getting some care, but since we can't provide it on the hospital track, they want you to change courses and at least get that care somewhere else. It is very interesting that a lot of those OBs that you're talking about have had to change their tune by 180 degrees. And suddenly now we're okay with midwifery care. And of course, me, I am like,
you're so okay with it.
I'm so okay with it that a lot of my colleagues don't even know where I belong, in which camp do I belong, right? But the reality of what's happening around most of the world, in which low risk pregnancies are being cared for predominantly by midwives, is becoming the reality in the United States right now. And the OBGYNs kind of have to be okay with it. To aid in that process, both the SMFM, which is the gray journal, and the ACOG guidelines, which is generally published in the green journal, these giant bodies, that's like the Society for Maternal Fetal Medicine and the American College of Obstetricians and Gynecologists, have both put out statements related to COVID-19 that do support, we need now more than ever, we need midwives, we need patients to feel supported in whatever setting it is that's best, because now we're forced to look at the risk of this COVID infection versus the risk of something bad happening at home. And by golly, we don't have a lot of data to support that bad things happen in home unless the obstetricians, gynecologists, and certified nurse midwives working in the hospital make it possible and make patients feel safe and comfortable pursuing community-based birth, right? And what I mean by that is that in the United States, sometimes we actually have, in some scenarios, we have worse outcomes for home birth patients than we do in, let's say, Denmark or the Netherlands or whatever. But that's mostly because midwives are forced to kind of wait a little bit too long to transfer to the hospital. They're forced to maybe not get that OBGYN involved in their community hospital, just because they're afraid that they're going to be lambasted or insulted or whatever else. And
it's a real fear.
Right.
I think it's pretty public knowledge at this point, but I was a practicing midwife in Oregon. And over 5 years that I owned a big birth center across the street from the hospital, the physicians I took transports to complained on my license 39 times in 4.5 years. Wow. So it's real that midwives are afraid of taking in clients. I continue to take clients in because that's appropriate care, but I spent over $100,000 defending myself against claims that were totally inaccurate. Yeah. So this is real. I mean, I'm a sort of an extreme example, but I just want to say that, we've heard in some of the literature a propensity to say, well, midwives are keeping women home too long, or midwives aren't transporting appropriately. Yes, and exactly. The reason is because they are literally risking their license by taking someone in. They're risking hundreds of thousands of dollars of defending themselves in court for normal transport. So, yeah, I mean, I never had a bad outcome. I never had a patient complaint. Every single one of those complaints I had to defend myself against were entirely physician driven. So that's one of those examples where this is happening around the country when we have these very idealistic camps that are totally, totally separate. We haven't had any bridging, is what I would call it, between the obstetrics and the midwifery. And it's really remarkable. This pandemic crisis has basically catapulted us forward 10 years. I would estimate 10 years in acceptability, communication, connection, recommendations, patient approval, you know, all of this. I think it's been, it's remarkable. There are doctors in Georgia who are actively campaigning against the licensure of midwives, and the bill was up this spring, this winter in Georgia legislature, who are literally being quoted by their patients as saying, "Go to this midwife."
That's just, I mean, it's mind-blowing. It's really mind-blowing. It's very bizarre. Yeah. I guess what I will be very curious to see is, like you said, if this is propelling us forward towards better, a better understanding of what's possible through the community-based practice of prenatal and birth attendance, I should say. What will happen when this COVID thing finally starts to dwindle? Are we going to see that same support? And are these physicians, or are these physicians, and maybe we should be optimistic, maybe these physicians are going to come to see the light. I'm not sure it matters.
I mean, because I think what will happen is that the birthing people will see the light.
Well, and if you ask people like Hermine Hayes-Klein or people that work, who hear all of the bad stuff happening to midwives and doulas around the country, if you ask them, it's really going to be a matter of women taking back birth. And this just being an opportunity for us to demonstrate that, hey, I know what you think about home-based birth because you see the negative, scary headlines and this and that. But the reality is that you're probably going to get just as good of care, if not better care, by going to a midwife.
Yeah, exactly.
So the silver lining of COVID.
all these birthing people who were previously like, oh, I guess I have to. Oh, I guess I have to have this ultrasound. I guess I have to have an appointment every 3 weeks, and I guess I have to do this test, and I guess they're like, wait a second. Now I don't, and everything's fine. It's something's different here. And then many of them have been like, okay, I'll go find a midwife. And then they're like, oh my gosh, this is midwifery care? They spend an hour with me on the phone. I can call my midwife whenever I want. I can decline things. I get full information. Wait a second, this is midwifery care? Oh, I want that. And I think that despite the pandemic and the crisis and the chaos, I think like word of mouth is always the best educator. And the community of midwives will be talking to this community of women and birthing people who will now be talking to each other and be like, you won't believe what happened. Even in the midst of this chaos, I could call my midwife anytime I wanted. Like,
I mean, talk about access.
Yeah, I mean, that's going to change many, many people's perspective. Yeah, so I think it's going to change. And I think long term, we're going to see this catapult for, because pre-pandemic, I've been a national midwifery educator and policy kind of talking about long-term systems development, things like that. And I have said, we are 15 years away from seeing the integration of midwifery in any kind of real way. But this pandemic, I'm changing my tune. I bet that, especially with the coinciding of the mom's bill that went through into Congress in this last session, earmarking $15 million for the education of more midwives in the United States. I think that, combined with the pandemic and physicians changing their tune so rapidly, I think we might actually be closer to 5 years away from seeing a real integration of midwifery, which would be so exciting. Because then we would be more online with the rest of the countries around the globe. Because right now, we are alone in our statistics and our utilization of midwifery. I mean, we lose the second most babies of all industrialized countries. We have the worst maternal mortality of any industrialized country, and we utilize midwives the least. Like, anyone who's intelligent at all can put those things together. We have the over-medicalization of childbirth has resulted in poor outcomes, period. So of course, bringing back the expert and normal into the care is the solution. They're not only that, but they're also less expensive. So the exorbitant healthcare costs in the United States could also be solved with adding midwifery. And the only major difference is that we are a for-profit medical system.
Right. Yeah.
And obstetrics has a for-profit hold on the majority of the market.
Yeah. Well, and I mean, there's a monopolization across the board within medicine. It's, it's a big system run by MBAs. I mean, that's why I left the hospital practice, because it's just not, it's not going to work. It's not going to, like, there's a bunch of, godless, sexless OBGYNs that are just cogs in the system that don't realize that things could be a lot better if you just open your eyes and realize that you are you could actually change this whole thing. If you guys all stood up together, and I mean, I say guys, I mean, men, women,
yes,
everybody in this camp, if all of them said, you know what, screw this, we're not doing this anymore, you guys would all be happier, you'd probably be better paid, you'd be able to go to vacation with your kids, you wouldn't have to do this mundane 12-hour, 24-hour shift in the hospital where you're just being beat down and you're taking home this tiny little piece of the pie and doing all the administrative things that some want you to do. And I mean, like, midwives actually provide the type of care that we all thought we would be providing when we became OBGYN, right? Where you get to know a person. And the thing for me is that I've had so many people, women, midwives, doulas, everybody calling and saying, hey, what's going on? I mean, they basically asked the same question you did to me. And I said, my recommendations haven't changed, guys. In fact, if I were you, I'd be going out and finding some way to stay out of the hospital, because if you're going to have a baby right now, do not go to the hospital. Like, you don't want to be there. It's lonely. There's no visitation. I mean, you might have your partner there, but it's going to be very weird. Everybody's very xenophobic. Like, that's not the place you want to bring this baby into the world. And I mean, my recommendations haven't changed, but now people are like, oh, you think COVID's going to be, is worse than all these other things? It's like, absolutely. You don't want this virus. You don't want to feel the tension inside hospitals where we are providing, I mean, I'm in palliative care as well. So you can imagine how the vast majority of my patients don't even have decision capacity for medical decision-making, and we can't touch them, and they can't have visitors. Like, you do not want to be in hospitals right now. So if there's ever a time to experiment with community-based birth, this is the time. Like, I promise you, you're not going to be let down.
That's awesome. Thank you for that clarity. We did a talk about a week ago with a group of stakeholders around the nation about how to open an emergency birth center during this COVID so that we can meet more low-risk, healthy moms. So if any providers are watching, go find that on my YouTube channel, because that it was really eye-opening. But I love what you're saying, this perspective. Like, if there was ever a time to consider community-based birth, now is it, because you don't want to be there. And I think if you have to be there because you have a high-risk condition or there's some diagnosed issue, like, that's why hospitals have always been existed, is for intensive, thorough, on-the-spot care of people who really have medical issues. Childbirth is not a medical issue.
Right.
It is a physiologic process. And actually, much like all the rest of our physiologic process, i.e. of the body and normal, it can happen at home. It can happen in non-medical environments. And so, that's been my recommendation. It's been yours. We're kind of, repeating ourselves here, but I think it's a little
validating.
Yeah, I think women need to hear it. I think that people need to hear it, and I'm certain that the policymakers and the professionals in both of our professions need to hear it as well. With thorough risk assessment and good monitoring, we see across the board across countries that actually community-based birth is very, very safe. So community-based birth is at a local birth center in your community, in your own home, at a midwife's clinic. And there are many, they're not enough, but there are many around the country. And midwives are extraordinary beings. They will do just about anything that you ask of them to their own peril, to their own detriment. There are midwives taking more clients all the time. Like, I did an interview with a midwife in Kentucky a couple of days ago. She is getting 30 calls a day for people wanting to
Amazing.
switch in rural Kentucky. 30 calls a day.
What's her name?
Wantina Brooks Roach. Do you know Wantina?
She's my lady. Yeah, I love her.
She's my lady. 30
Amazing.
calls a day.
I have to reach out to her, and yeah,
you
that's
should.
amazing.
Yeah,
Wow.
and she's doing. She laid out this very thorough risk assessment where she sent them to go assess her FAQs and her, and then they would get the records sent, and then she'd spend an hour reviewing the records. Then they do a phone conversation. Like, she had this whole process where she could only accept people that were appropriate. But she did 10 births in 14 days.
Wow.
2 of them to people that she'd never met before. Like, that's
Wow.
the kind of show up and support the community that midwives do. And it's just exceptional. I mean, it's just exceptional. So anyway, we could cheerlead for midwives all day long. If someone has to birth in a hospital for whatever reason, financially, personally, risk factors, high risk status, being a more naturally focused OBGYN, a more holistic family focused OBGYN than many in the country, having practiced in the hospital, do you have any advice for those families that do choose to or have to birth in the hospital during this time frame? What should they do?
Honestly, I think it just comes down to communication, and I think it really comes down to protecting yourself as well. The virus, this novel coronavirus, and the infection that it causes, this COVID-19, it's highly contagious. And if I was going to be in the hospital, which I am, I'm washing my hands frequently. I'm not touching my mouth and my eyes. I don't want to get the virus, but remember, it's still a virus. It's killable very easily. Using your hand sanitizers and your Clorox wipes and all that other stuff. You just have to be kind of aware of that. I think that if I was planning to go to the hospital and I didn't need the safety of the hospital to keep me alive throughout my labor, right? Like, there are some people who were born with a congenital heart defect, and they had a massive Fontan procedure or something that would require very, very close monitoring, maybe monitoring of their heart rhythms and rates, monitoring closely of their fluid statuses. Those types of things are good reasons to have hospitals for women who potentially could die in labor, but that is obviously the minority. If you're a low risk patient that is also planning to go to the hospital, the only really thing that you need to do is minimize your exposure, and that's going to mean waiting as long as you can in the labor to go to the hospital. And if it's your first pregnancy, you probably don't know what it feels like to be in that sort of second stage of labor. But I will tell you that the less time you spend in the hospital, the better. And if your contractions are not coming or if your surges are not coming every 2 to 3 minutes, and they're not lasting for at least a minute at a time for a whole hour to 2 hours consistently, you're probably not in labor. So that back and forth to the what we call the triage, right, where you get evaluated, are you in labor or not, and the physician, it should be kind of a conversation with you about whether or not it's time to be admitted. Minimizing those trips to the emergency room or to your hospital's OB triage, I think, is probably the best thing you can do for yourself, because the best case scenario is, like with my wife, fortunately, I'm able to check her cervix. So I did at home, and she was 9 centimeters, and we went to the hospital and had a baby. That's like the ideal hospital-based birth, right? She didn't need medication. She didn't need anything. She didn't need sutures afterwards. She had no laceration.
Yeah.
It was easy,
super
breezy.
Mom. Yeah.
Right. She went up to she's leveled up, and
yeah, totally. She's the goddess. You can kneel at her feet now.
100%, 100%. If well, not worthy, if you can somehow recreate that, that's the best scenario. And I think that if you wait until your water breaks, until you maybe have a little bit of bloody discharge, something like that, that'll tell you that, hey, the cervix is changing. You're not going to be in the hospital for an additional 2 days in labor.
Yeah.
You go in, you have a baby maybe in a couple hours, and you stay until the next morning, and then they send you home. That's really what you should be trying to achieve. And if you have any questions, hell, I'll give you my cell phone number. You can just call me and say, hey, am I in labor? Text
Be
me.
careful.
I'll text you back.
You might have a nation of women calling you. Well, so one of the best ways to stay home is to have a doula with you. So we're seeing this also the second profession of
Great
doulas
idea.
who are rising to the challenge and saying, I will do virtual appointments. I will do telehealth visits with you. I will come to your home and stay with you until it's time to go. So that's another huge resource. And doulas are no less amazing than midwives, but they have a totally different job description. Doulas are non-medical labor support. They cannot check your cervix or listen to your baby, but they are experts in how labor unfolds and coping mechanisms to get through, especially that early stage that you're talking about. So that can be an incredible resource.
Yeah.
I did have another question for you. What about leaving the hospital early with your baby? That's a question that's been going around some chat rooms. In non-pandemic stages, it's kind of frowned upon, and some hospitals will make you sign an AMA against medical advice to take your baby home. What do you think about that now?
I mean, I'm 100% in support of it. I think that there's a couple of things that keep babies in hospitals. The baby's got to be breathing on its own, the baby's got to be eating on its own, and the baby's got to be pooping and peeing and not showing signs of infection, right? If all those things are working out okay, then there's really no medical reason, as long as the mom's health is checked out, for you to stay any longer than 12 hours or whatever. But we've developed this process whereby we want to make sure that the baby's not hyperbilirubinemic, that the baby's not developing an infection later. And so they generally like for at least a 24-hour period to monitor the baby. I think nowadays, I think that it's going to be a lot easier to convince the pediatricians and the pediatric staff to sign off on that. I know from the maternal standpoint, it's a lot easier now, because the less patients in the hospital, the less PPE we're using, and less nurse contact, less staff we need to take care of them. If you're asking if I think it's unsafe, I don't think it's unsafe. They're still going to likely have a visit with your pediatrician 24 hours after discharge anyways. So let's say that you deliver at 5 a.m. I would probably say do your best to stay until at least later that evening and then sign out. By then you probably would see signs that something was going wrong. And then, what we can do on the medical side is we need to get better at just giving people a really good education as to what would be a good reason to come back. And in the age of COVID, that might be the best option right now, because if you end up with a woman with COVID and she's on a ventilator, who's taking care of the baby? We have to keep that in mind. So the risk of that happening versus the perceived benefit of keeping a baby here for 24 hours is kind of crazy, because now you have two potential infected people, right, going forward, and that's a lot harder for the medical system to kind of manage. So I don't see anything unsafe about it. No.
That's awesome. Well, do you have any other recommendations for mamas who might be watching this video? Anything that you would like to get out there?
I think that I think that there's this sort of model of hospital-based birth from the maternal standpoint that I didn't fully appreciate until we gave birth, and then a friend of ours who was a couple months behind, she gave birth recently, but she'd asked my wife for some input, and she had said, "What Netflix shows did you download for your labor?" And my wife was like, "Netflix shows." I was channeling, some other power to get through those hours. And it was only 6 hours, but it was a very intense 6 hours. And, so for women who are planning to maybe have an epidural and everything, that's totally fine. But what I would like to add to that is that there's a lot of internal work that can help you through a very stressful time like labor. And now that we're talking about an extra stressful time in labor, given the risk of this virus and everything, it's going to be an intense experience. And I always encourage women to do the internal work that's going to help get them through that process, but then to also think about what is life going to be like afterwards. And Augustine, you gave me this advice. You said the day of your birth is important, but the next 18 years after that are more important. And, my partner and I have a very loving, very deeply connected relationship. And had we not spent the majority of our time not preparing for the birth, that was really Stephanie, me helping with visualizations, we did some hypnobirthing stuff, whatever, that is important. What's more important than that, though, was the additional 80% of our time spent talking about what she and I mean after this, given that now you have to raise a baby in quarantine. And that's a scary thing. It's scary to bring a baby into the world right now. And when you can't even have your friends and family come to support you, you need to really have a firm planted foundation, right? Of who you are and what this household is going to be for potentially the next couple months. It's stressful. Or years. I mean, this might change things. Yeah, this might change things for a long time. So the birth is great. The birth is actually it's going to be easier than you think. The stuff that comes afterwards, I think, is really challenging. Today was a rough day, and I've been losing sleep just thinking about how these economic stimulus packages are really not going to do anything for economic growth after the fact. And, that's one little tiny thing, and we have a baby, and so, if you aren't doing the work with your partner, with your family, thinking about what all of this means, you might have the rug pulled out from underneath you, and it might be a big scare. So I would encourage everybody to do the internal work, the partner and the birthing woman, do the work for the day, but do a lot more work as well for afterwards, because this is challenging times.
Yeah. And I have one resource that has really helped families in the past that I'll throw out there. In the back of the Birthing from Within book by Pam England, there's a section, a little tiny section, I think it's like a page and a half, about how to write a postpartum plan. And I love this resource because we spend so much focus on writing a birth plan in our culture. But truly, a birth plan is the 24 hours, maybe. And then there's the rest of your lives. And the new postpartum period is really intense and overwhelming, or can be. You have literally a new human. There's this great analogy that, like, you're driving down the road of life and you stop to pick up a hitchhiker, and then they stay with you for 18 years. And like, that's how strange it is, right? Like, who is this little human that just joined your life forever? You don't know them, and they don't know you. And it is that stranger kind of relationship. And yet their body is helpless, and they're responsible for your everything makes them live. And yet their demands are great. And the shift and the adjustment in your own life is great. And it can be really, really overwhelming. So understanding division of labor, like, that's one of the most simple postpartum plans. Who's doing what, and how are we going to get okay with that, so we're not always resentful at each other? And who's responsible for what part of all these new jobs? And then all the old jobs, like house cleaning and dinner prep and like things that you used to enjoy together, you can't because someone always has to be doing the baby. These are important things. And Pam England's resource, the postpartum plan, it's ridiculously simple, but it can be really helpful. And then your recommendation of sitting and talking with each other. How's this going to be? How can I support you? How can we still be us?
Well, and I'm glad you mentioned that last part. How can we still be us? We one important thing. So this is, I guess for some people it might be TMI. It's not for me, but we had intercourse at about 5 weeks, 6 days after the birth, and it's supposed to be like a full 6 weeks. But we were like slow dancing in the room, in the dining room, and the baby was sleeping, and she was like, "Is it 6 weeks tomorrow?" And we were both like kind of feeling each other, and we then we had like an evening together in the guest room, and it was like really, really romantic and very, very short because we were kind of like worried about what was going to happen. But that's going to stick with me forever, because what is most important is you are not now parents, and this is something I'm learning. You are not now a dad. You are not now just a mom. You're now a mom, a wife, my wife is trained to be a pilot. You're a brother, you're a sister, you're a whatever. Like, you are a fully intact human being, and you have to continue being a fully intact human being. You can't make this your only priority. Otherwise, this quarantine stuff, and even just being a mom outside of this quarantine thing,
it'll make you crazy.
It will make you crazy. It has to be balanced. It can't be.
And it'll alienate your partner. And I think that's one of
100%.
biggest casualties of the American culture, is that when parents become parents with our, over simplification of everything, hypersexualization of our culture, and then this Madonna sort of like Mary focus of mothers being separate from sex, it's created this idea that once you're a mother, you're not anything else. And actually, nothing could be further from the truth. There's something about becoming a mother that actually turns on your sexuality for lots of people in ways that it
Oh,
never
yeah.
did before.
Oh yeah.
And so I love that you guys are discovering how to
Yeah.
stay deeply connected in all the ways that you can while
Yeah.
you're sharing this new job called parenting. It's
Right.
beautiful. Thank you for that deep share, and thank you for everything that you are in the world. I'm so glad to know you.
Oh, I wish we lived closer and we could have dinner more often and
know.
have snuggle parties. Yeah, you're a really special person. I'm glad that you're doing this work.
Thank you, Nathan. We'll talk soon, okay?
We
Thanks
will.
for doing this. Okay.
You're welcome. Bye.
Bye.